We've now completed 70 nights at home. These were the first studies approved, I think, by the FDA where you're in home, where these are people that are just doing this at night. I love these studies. All the other overnight studies, I had to stay awake. And for this, I wake up in the morning and I get their download and I go, oh, that's interesting. And so you can do these just really quickly. So we'll have completed 200 nights and 20 subjects in the next 30 days. And we just got, and we're submitting to the FDA to do a study where we'll have 45 subjects doing 42 nights. So within a few months, we'll have 1,600 nights of data of people using this system. And if you want to sign up, we need subjects. So,
what age range?
Well, the current one, the FDA is always, they want to do people over 21. So the current group is over 21. When we get this one approved, which will be in a month, we're going to go down to age 15. It'll be 15 to 45. So the other study we're doing is not only preventing the low, but also the high. And this is sort of a typical pattern. Why is the blood sugar going up here? 5 minutes. Okay. It's going up because at noon he forgot to give a bolus of insulin when he ate lunch. And then he got alarmed here, and then he gave a big bolus to correct it, began going down, and saw his blood sugar going down, suspended his pump. So this missed meal gave him high sugars for about 12, 18 hours. And the data is that 65% of adolescents, this may shock you, shocking number. 65% of adolescents miss more than one meal bolus a week. 2 missed boluses raises your A1C by 0.5%. This is from Peter Chase. There was a study done in Australia. If you miss breakfast 2 times a week, it raises your A1C by 1%. If you have less than 2 food boluses on any given day within 2 weeks, your A1C goes up almost another percent, 0.8%. If, on the other hand, you take 7 boluses a day for more than half the time, your A1C is generally 1% lower. So it just is one of those amazing facts that insulin's a good drug if you use it. And so this is a study we're doing. It's a multi-center study with University of Virginia, UCSB, Barbara Davis Center. We're also doing it in Italy, France, and Israel. And there are 25 adults. We're going to be doing adolescents, 12 to 18 years of age, and it's a 30-hour admission where we give them a missed meal and meal over bolus and exercise them and really try and test this controlled range system. And we've done one, and in the next 3 months we'll be doing 6 subjects for that, and they need to be adult, 18 year age. This is sort of the same principle. This is using a PID control. When your blood sugar is going high, the controller kicks in, delivers insulin. If your blood sugar is getting low, it begins to shut off insulin delivery. And if you're in range, if you just were managing your diabetes perfectly, this thing would never kick in. So it's what we call a hybrid system where you can give your own insulin and control it, but if things begin to go high, you misestimated carbs, you forgot to bolus, something crazy like that, then it will begin to take over. And we've done 3 subjects to date using this system. This is a Medtronic system. We have 5 more subjects we want to recruit for who are over 18 on an insulin pump. And then last week we received FDA approval for a new set of studies. We're including now Yale and University of Colorado with us in doing these, and we're using a pump. These will be in 15 to 40-year-olds with an A1C less than 10. So again, looking for volunteers. And this is a TrialNet study, and it was to say, at the onset of diabetes, can we prolong the honeymoon if we keep the blood sugars in tight control? If you don't expose those islets to a high glucose, islets love a normal glucose level. They live to maintain a normal glucose value. If you expose them to a high glucose, they die quicker. They're more susceptible to the immune system. So we were saying we're just going to keep their blood sugars as close to normal as possible and start this within a week of diagnosis. So they came in 44 randomized to intensive treatment, 22 to conventional. We have over 3,100 hours of hybrid closed-loop control doing these studies, 132 days and nights. And I can't see this there, but before they came in, the mean glucose was I don't have it before they came in, but the first 6 hours, the mean was 163. At the end, it was about 138. These are the percent below 50. You see 0% through the whole time. Percent above 250 went from 8.531%. They were able to eat whatever they wanted. Here's 2 double order of fries, 2 hamburgers, chips. These kids had just been diagnosed with diabetes within a week, and they were really hungry. They had a lot to make up. And some of them ate up to 4 grams per kilo at a meal. 4 grams per kilo. If you're 70 kilos, that's 280 grams of carbohydrates per meal. I mean, it's a lot. And we got this. This is their blood sugar control before they came in. Big standard deviation. This is on the closed loop. And what was exciting to us, this is when we sent them home on a sensor minute pump. We maintained that level of control. So we brought them down, clamped their blood sugars, and kept them in control. This is the girl that went the longest. She took a lot of videos to do that. She went 4 days. This was her blood sugars before she came in. This is on the closed loop. This is when she went home. If you have someone not using a closed loop, this is what their blood sugars look like when you go home for the first week. They're all over the place. Oops. This was her first week at home. These were her blood glucose levels. But it was sort of amazing. She's now gone away to college. This is 2 years after diagnosis, and these are her blood sugar levels. A1C is 5.8. She's on a 3rd unit per kilo. Only 1% are less than 70. That means she's making her own insulin. You can't do that with shots. So the question is, how many sensors, how many times? Do you need fluorescent? Do you need an opticode? Do you have to have the sensors in different sites? You need to be able to detect the onset of eating. We talked about sensor failure, infusion set failure. You want to be able to prevent those. It needs to be lightweight and portable, easy for someone to use. It's the human interface, the real estate of skin, and how much tape and pull-on things on and off your body you're going to have. You want to not have a lot of devices to carry. And you also want it to be your cell phone, your internet. So, the iPhone, talking to your sensors, talking to your pumps, and there's a lot of talk that the FDA has reservations about this, but kids would really love it. And this is sort of my vision of, I hope this is going to work. Oh no, I got the wrong set. I worked so hard on this. Oh, there we go. So this is one platform, and it has a sensor and transmitter with a battery going in. And so this would be for your sensor. This would be your MEMS pump, an insulin reservoir. There are 2 needles going in. I would actually use steel. It would talk to your iPhone to the cloud, which would then be available to anyone that has cloud access. And I'd probably put a little accelerometer in it to measure activity. Because these are in the center of the platform, if you rock up and down here, you're not going to rock the needles out. It's at the fulcrum. And this is clear. You can see through and see the sides. And so that's my vision. Email me. That gives me permission to email you back. Buckingham, Stanford, and these are the ones we're doing. Thank you.
One comment I wanted to make, you're hearing names of products and devices and things, and UCSF is not endorsing in any particular product. We don't have any financial stake in any of these. I think we just want the best products to move forward. So feel free to talk to us about that further.
I didn't give my conflicts, but I tend to be promiscuous, and I try to have relationships with everyone, except women. No, forget it.